fact that we are actually identifying all of these patients with cardiometabolic disease is really important, because we can then initiate appropriate treatment. What we're not necessarily as good at, and it's actually making me think that we need to go back and just check our screening history, to Monica's talk, is making sure that we are incorporating the sex-specific and the gender-specific risk factors. I do that in my own practice, but I too can be, 100% honest. I can't recall how careful we've paid attention to those sex-specific risk factors, the gestational hypertension, gestational diabetes, these sorts of things that we need to be incorporating in our patient cohorts, particularly in the rheumatoid arthritis patients, because they are disproportionately women, just like in the lupus patients that I see as well. And so that's something that we can just make sure that we're doing as a quality control room for our outcomes. Lihi, did you want to comment?
Yeah, I think, you mentioned the importance, and what we do in the clinic. I realized that not every rheumatologist or family physician have all these resources that we have here at Women's, with high and sophisticated imaging modalities. But I think it's, when we talk about the difficulties of predicting cardiovascular diseases in these patients, because the scoring systems may not function as well. But even without all the adjustments that have been suggested for risk stratification, just screening for risk factors is really important. And even using the guidelines from the general population to manage lipids and to manage diabetes and blood pressure, because we and others have shown that there are huge gaps in care, and many patients rely on us as rheumatologists to manage all their comorbidities. And I'm not sure we can do all of these, but we can certainly, when we see the patients, measure the blood pressure, take a lipid profile and do lipid profile once a year, and highlight these abnormalities and communicate with the family physicians to make sure that these are managed. And I wonder if Alexis can add a few more thoughts about how to improve this process. She's touched upon that in her talk. So Alexis, do you have any thoughts?
So I think, just so from the bottom up, like most practical for me, for example, is I just have it as a part of my note so that I know that I'm addressing it every time. So my note template always has that. And so if I'm always looking then and thinking about that and communicating it, so it's first because it's in the note, it's communicated with the primary care doctor, because it's in the note, I'm talking about it with the patient and the patient seeing it. So even just having some simple reminder to think about it every time is helpful, even if we'll discuss next visit. But I think all those things that you said are exactly right. And then it also, I think, getting in the habit of looking at the glucose. I picked up a lot of diabetes when we get all of our labs for our DMARD follow-ups. You pick up that little bit elevated glucose, and then at some point it's 200, and all of a sudden the patient has symptoms. And so I think we end up diagnosing diabetes a lot. So I think anything that just draws your attention to those is at least a base level of awareness that's really helpful. But having a kind of a more sophisticated plan for how to assess those is really important too.
Can I add in also that this is where the importance of the family doctor is? I know it's a little different in the US, but this is where you need to have that hub in the wheel, because we do know that patients that have chronic diseases tend to get into a stream with specialists, and that can actually negatively impact their overall healthcare and attention to primary prevention. We know that whether it's cancer screening or for sort of metabolic, and that's where we need to really make sure that we've got the family doc engaged. And sometimes that requires, to go to back to your presentation, Alexis, about the patient having to be on board and being part of that and recognizing the importance of the team. And that part of that team is the family doctor, who can really help with managing. It doesn't have to be coming to a cardiologist. Family docs can manage their diabetes and their elevated LDL, etc. So I think, that's a really important thing to highlight. It doesn't have to all fall on the rheumatologists. It doesn't all require a referral to to a cardiologist. The family docs are critical.
Thank you for that. I mean, it really struck me on your opening slide, Dr. Eder, right early on, the number of people who do not have their lipids appropriately managed, right? I mean, that seems like the low-hanging fruit piece here. And that needs to be better communicated, I think, to primary care. And whatever implementation process or studies you're doing, it would probably be helpful. One, you've already talked about embedding reminders in EMR. That's always one of the things that works for, at least at the primary care level, for sure. That's how we get on top of our screening, right? In terms of our cancer screening and other initiatives and our hemoglobin A1Cs. And also just engaging primary care on your research team and patients on your research team, of course, so that you can just, make sure that it's going to be transferable at the end level. And of course, ideally publishing in some family medicine journals, just so we're at least aware of it, would be helpful too, because sometimes that gets forgotten. You get with all your specialty groups and forget to send that information back to the family doc. So that would be helpful as well. So carrying on.
Can I just say one last thing? And that is that, not every condition is the same. And we know that psoriatic arthritis in particular has a particularly adverse cardiometabolic profile. So you can almost immediately assume that you're going to find something, I think, in your patient that has psoriatic disease. And so it's always worth, have your radar up to everybody out there, and think about the PSA patients. I mean, they're all really important, but you're likely to find something in those patients, as we have shown, and others who have done research looking at their cardiometabolic profiles.
So again, that message would be important to communicate more broadly. Sorry, I see Andrew has your hand up. I'm just going to go to the one segue into this one question. I'll lay it on the table, then I'll go back to you, Andrew. What are the differences in cardiovascular comorbidities between RA and psoriatic arthritis from your experience? You've sort of touched on that. Is the awareness of cardiovascular comorbidities similar between RA and psoriatic arthritis among community rheumatologists? And thank you. Do you want to go first, Dr. Crane, on what you were going to speak about, and then we'll go into that one? Or okay, so who would like to address that?
Alexis, do you want to take it?
Sure. So we've actually examined that as well, looking at RA versus psoriatic arthritis versus psoriasis and cardiovascular outcomes. So on average, patients with rheumatoid arthritis are about 10 to 15 years older than patients with psoriatic arthritis. So they get some more of that age stuff at any one time point. Considering age is really difficult in studies because there's so much that wraps into age. But in general, patients with rheumatoid arthritis are thought to have the highest cardiovascular risk. And then psoriatic arthritis kind of just a step below, along with severe psoriasis. Those are kind of on the same plane. And then mild to moderate, mild psoriasis in particular has just a very minimally increased risk. But it's the more psoriasis you get, and then the more severe your psoriatic arthritis probably also counts as well, and probably pushes you closer to that RA region. Now, if you account for the age component in kind of interesting ways, it actually looks more similar between psoriatic arthritis and RA. So I think that's something to keep in mind as well.
Thank you. At the last conference, there was some evidence presented that methotrexate may be cardioprotective. Is there any more evidence? And what about biologics?
I could take this one. So I think methotrexate has been investigated extensively especially in rheumatoid arthritis. There were some studies in psoriasis. All of these studies were observational studies. So that's a main limitation of the data that we have, because patients that are put on these medications are different than patients that are not put on medications, especially methotrexate, that have some concerns regarding different comorbidities. So patients that are put on methotrexate might be a bit more healthy than patients that are not put on methotrexate, which might confound the results in ways. So, but overall, most of the studies have shown a protective effect for the use of methotrexate with respect to cardiac diseases. I'm not aware of any studies in the past year that show differently. I think with respect to the biologics, there were concerns initially with the TNF inhibitors in the context of congestive heart failure. because these medications were trialed as a treatment for severe heart failure and failed. It actually showed worsening of heart failure. But over time, we've learned that, I guess, in patients with mild heart failure, I think many of us feel more comfortable prescribing TNF inhibitors. In terms of cardiovascular diseases, TNF inhibitors being the first biologic entered into the market have been mostly studied, and many of these studies again showed a protective effect. Again, there are no randomized control trial that looked at clinical events. And with respect to the newer biologics, there are many of them. And I think the most interesting data from the past year is coming from a study that assessed a JAK inhibitor called tofacitinib in patients with rheumatoid arthritis. So this study enrolled patients who were at high risk of developing cardiovascular diseases and compared tofacitinib to TNF inhibitors. And there were some, so this was a non-inferiority study. So they kind of failed showing that JAK or tofacitinib is as safe as TNF inhibitors with respect to cardiovascular diseases. So this raised some concerns regarding the use of this specific class of biologic in patients who are at high risk of cardiovascular diseases. But I think we need to wait for this was not published as a full paper yet. We need to wait for the full publication and understand who are these patients that are at high risk. And certainly these were all rheumatoid arthritis patients, so it's really not clear how these results translate to other groups of rheumatic diseases like psoriatic arthritis. But it just, I guess, raised new concerns about potential adverse outcomes of cardiovascular diseases in these patients. I don't know, Alexis, do you have anything to add?
Yeah, I was just going to, add the methotrexate question is really interesting. And this is where the idea of inflammation versus disease activity comes into play, because Paul Raker published that trial in methotrexate, low-dose methotrexate, which was 15 to 20 milligrams, so about what we use for rheumatoid arthritis or psoriatic arthritis, and found really no significant difference from placebo in terms of cardiovascular events in this kind of elevated risk population. So, just that there's lots and lots of things that have come up about the trial. Did they kind of have enough people in the trial with high enough inflammation to actually see a difference? And that was unclear. Is the dose not high enough? That was unclear. But I think it does still raise the question, do these medications really reduce inflammation as the pathway to improving cardiovascular health? So lots of questions. So that trial raised as many questions as it did have any answers. But
I think also with the biologics, it's interesting because we're drilling down to different interleukins, etc. And we don't know necessarily if all of these are involved in atherosclerotic disease and inflammation. So I wrote an editorial with Aaron Drucker, who's a clinician scientist and dermatologist here at Women's, and we were looking at whether or not atopic dermatitis, which again has different inflammatory pathways as part of the disease entity, whether patients with atopic dermatitis are at increased risk of cardiovascular disease. And when we looked at the inflammatory mediators that were involved in the two, in atherosclerosis versus atopic dermatitis, and the study that was linked with that editorial, there didn't seem to be a link. And I think it just, as a person working in the cardiology area, not in the rheumatological or dermatological, it just re-emphasized to me that there's likely to be there are different inflammatory mediators that are involved in different inflammatory processes. It just made me think about it in a more sort of sophisticated way. And I think that's probably where we're going as we look at these different trials, as we're trying the different biologics.
Thank you. Just so everybody knows, we will allow the full 45 minutes, which will give us another sort of 15 minutes or so to go if there are enough questions. But Dr. Piquet has to leave us shortly. So one last question for you. In patients with isolated psoriasis, at what level of severity, mild, moderate, or severe, should a patient be considered high risk for cardiovascular events to go through a detailed risk stratification, similar to what you might do for lupus or RA?
Yeah, thank you. So that's a very good question. I think it's been touched upon already by Alexi earlier. My understanding is from the studies is that it does correlate with the severity score for psoriasis. So if you have a lot of skin psoriasis, it's more likely that there's a risk. I think, as you know, everyone has discussed already, it has to be taken into account with all the comorbidities, the other risk factors, et cetera, et cetera. So I don't think we have a specific number that triggers a referral to a specialist or even to alert the family doctor about screening. But I'd say as just a sort of average number, we could use the body surface area of the amount of psoriasis. It's an easy way to remember is 10 palms of the hand. So that's 1% body surface. And so if you have 10 of those, that patient will have about 10% body surface area affected by the psoriasis, and is probably going to be in the moderate to severe psoriasis group. And so that group, I think, has an elevated risk, as we discussed earlier.
Thank you. One question: can we send patients for any of your studies from Niagara?
The answer is yes. So we have a website at Women's College website. You can find our clinic there, and there are there is a referral process that we do see patients from outside of our hospital.
Thank you. We do have some questions of somebody who has identified themselves, a physiotherapist, Maureen Dwight. Welcome, Maureen. She's asking us, saying heat has been claimed to help many rheumatoid arthritic patients' joint symptoms. Is there any evidence to support this? These are the tough questions.
Yeah. I don't know that there are any evidence to support it. I know that some patients find heat to be helpful in terms of reducing their joint pain. I don't know any other rheumatologists in the panel, of Fear or Alexis, any thoughts, comments about this?
Okay. Physiotherapists may see clients with symptoms of suggesting undiagnosed myositis. Which muscles should be tested, and what level of strength loss is significant enough to consider referral back to the physician? So maybe that's
yes,
Yes,
I think we kind of touched on that at the end of my talk, but just to repeat, the key is really looking at proximal muscle groups when we think about connective tissue diseases involving muscles, myositis, lupus, and so on. And the proximal muscle groups are the deltoids, biceps, and triceps in the upper extremities, and don't forget the neck flexors and extensors. And in the lower extremities, the hip flexors, probably the most commonly affected muscle, as well as the knee flexors and extensors. So these are the proximal muscle groups, and really any degree of weakness, and that would usually be symmetric. So these conditions do affect the muscles in a fairly symmetric way. So symmetric proximal muscle weakness, if there is a degree of weakness, certainly you would start at least some basic investigation, blood test, biochemical parameters, EMG, and so on.
Can I ask Ophir another question? Ophir, there has been, well, I know that there is an entity of autoimmune or inflammatory myopathy associated with statin use, and with our patients specifically, this has come up as in the differential diagnosis. So can you tell us a little bit about it, and when do we have to think about it, as opposed to the adverse, more common adverse effects of statins that are not autoimmune in nature?
For sure. I think I will just use it also to make the comment that that case is incredibly complex. That specific case that was presented, that's not definitely not the typical common thing that you would see, and he has a lot of other factors like the malignancy is another important component in his presentation as related myositis, because we know that strong association between cancer and inflammatory myopathy. When it comes to the statin, what I refer to as the statin spectrum of muscle effect. And just like you alluded to, on the one hand, on the kind of mildest of that spectrum, you have the asymptomatic CK elevation, the myalgias, and these are fairly common. To the more extreme and rare complication of acute rhabdomyolysis, and that's where the medication will cause just acute rhabdo. You stop the statin, it the process stops. To the most rare, I would say, complication, which is this entity of necrotizing autoimmune myopathy, or NAM, that has been really increasingly recognized over the last, I would say, 10 years or so, where the body develops an antibody, anti-HMG-CoA. So it develops an antibody against the HMG-CoA reductase enzyme that the statin targets. And stopping the statin does not stop that process. It becomes a self-propagated autoimmune disease that then requires chronic treatment. Some of the kind of clinically relevant features that would make you think about it, of course, first of all, is the statin exposure. And I would say that it's probably most commonly seen within the first year of use of introducing a statin, but can also happen years after being on the medication. And there are different factors that go into it. One is age, and that relates to the pharmacokinetics of the medication. Decrease in renal function can be another risk factor of developing statin-related muscle complication. So what might be a case that can present later on, not very acutely in terms of temporal association with the statin introduction, is, for example, the patient who had an MI was put on high-dose statin. 5 years later, they have decline in their renal function. They're 5 years older. Other medications are introduced, leading to some drug interactions. The statin dose wasn't adjusted, and they can then develop a statin-related complication, including this one. So most common early on, but can also happen later on in the use of the medication. The presentation is typically, it can vary. It can be fairly acute, but it can also be more protracted. It can be preceded by a period of time where there is just very high CK elevation, but no overt weakness before the actual weakness starts, or it can be a more profound acute type of presentation where the patient presents with fairly rapidly progressive proximal muscle weakness. A hallmark of this entity is extremely high CKs in the thousands. Many times people have myalgias, which is otherwise not a common symptom in idiopathic myopathies, dermatomyositis, lupus-related. Myalgia is not that common, but with the necrotizing myopathies, statin-induced myalgia is probably a little bit more common. And in most cases, you will not see other extramuscular manifestations. So you won't see the typical textbook dermatomyositis rashes, the heliotrope rash, the Gottran's papule. They won't many times have any cutaneous manifestations, and they usually don't have interstitial lung disease. There is usually not a strong association with cancer. So it's truly a progressive proximal muscle weakness with very high CK.
Thank you for that. A couple of questions about HRT. Any role of HRT in cardiac issue? Some patient found symptom relief while on it. And then another one, I have a patient put on estrogen and even testosterone by a naturopath. Any comments on cardiac risk? So relationships between HRT and cardiac.
How long have we got? Let me see if I can distill that down. So obviously HRT is obviously a complex discussion, just like inflammation and the rheumatic disorders is a complex discussion. And I think we've learnt the complexity of HRT over the last few decades and started to think about it in a much more nuanced way. So we don't use HRT in the cardiac world for cardioprotection. We do believe that endogenous estrogen, so when you're premenopausal, endogenous estrogen does seem to have potentially some component of cardioprotection, just part of when you're talking physiologically, but when you're talking about pharmacological doses, so hormone therapy, then it's a much more difficult discussion. And one of the things that we know from the clinical trials back from the sort of around the 2000s was that there does seem to be difference in patient or populations of women, particularly based on age and background atherosclerosis, as to how you might respond to hormone therapy. So we have the timing hypothesis. So if you're very close to the onset of menopause, where you probably haven't had development of any significant atherosclerotic plaque, that you may take estrogen without any increase in cardiovascular risk, particularly if you're using transdermal, which is sort of the most physiological replacement. As women start getting older, then they do have an atherosclerotic burden in their vessels, and there's evidence that estrogen then has different effects once you've got atherosclerotic plaque present, that it has different effects. And so, it really is a discussion that has to be patient-based, individual patient-based with your provider about age, risk factors, and what type of estrogen might be used and why you're using it. So short-term estrogen, if you don't have cardiovascular disease, we know it's different. If you've already had an event, you shouldn't be on estrogen. If you've got significant atherosclerotic burden because you're older and got a lot of risk factors, or rheumatic disorders, we don't have clinical trials in people with rheumatoid arthritis, etc. But I would be concerned about, especially the older patient that might already have plaque burden. So I think what needs to be done is it does need to be thought through why you would put somebody on estrogen, because it's not going to be for cardiac prevention. It's going to be for amelioration of menopausal symptoms. And then looking at the individual cardiovascular risk, how long you'll be on it. And you can use topical, as in transvaginal, without having to use systemic estrogen is a way of thinking about things. But if it looks like your patient doesn't have have atherosclerosis, has never had a cardiovascular event, is within 5 years or so of menopause, that it's probably safe. It's not for cardioprotection, it's amelioration of symptoms. And that's where it's often good to use, you use the minimum amount of estrogen that's required to ameliorate those symptoms, and often good to use transdermal because it's the most physiological. Then you have the progesterone, which also is a little bit of a complicated story as well. And it does, if you're looking at some of the complications from hormone replacement therapy, the progesterone is actually probably one of the culprits as well. So it's a complex conversation. It's evolved over the last few decades. Since I started working in this area, I actually did my PhD on it a long time before I came to Canada. But it really does need a detailed discussion and to look at some of the updated guidelines where they've started to be much more nuanced in their recommendations. Hope that answers the question.
So we have a few more questions, and I guess I'm looking to the organizers. We only have a couple of minutes if we stick to our 45. Do we want to go a little beyond our 45 and cut into the networking? Or I know we've lost some of our panel people here, so let me know, Dr. Etter and Harvey, what would you like to do?
Are there many more questions that have come in? I'm just having a look.
There's about 3 more questions that have come in. Go for a bit more.
Leahy, we can't hear you.
I guess I was saying maybe we can select maybe the top question and then we can wrap up.
Okay. Thanks. Oh gosh, you're putting that one on me, right? Somebody wants to know if Plaquenil can cause a cardiomyopathy. That's too long. Okay, I'll take a shorter one. In patients with morantic endocarditis, is anticoagulation helpful to reduce embolic risk if the masses on the valve are large and mobile? A very specific question.
Well, I would say yes to that if they're large and mobile. Anticoagulation.
Okay. That's a good short answer. And then we can't let people, you know, I don't think we can let everybody go without thinking about what's right in front of us in the world today, which is now these cases of myocarditis in people post mRNA vaccine in our young population. Anybody want to weigh in on that and where we think we're going with that? Are we going to head to reduce the doses of mRNA vaccine in that group, prolong the time period? What do you think about the risk of that and how that's going to impact our pandemic recovery?
Tosin, do you have any information about that? I know you're following the COVID and myocarditis fairly closely.
Yeah, I mean, so there have been increased cases of myocarditis, particularly in young men, noted in the US, noted in Israel, after mRNA vaccines, specifically Pfizer vaccines in the younger age group. Thankfully, these cases have been mild. 95% of them are mild. There was a case series on 7 adolescents from the US, and they also had very mild illness. All of them at the moment are after the 2nd dose of the vaccine. All of them in that 7 case series from the States had chest pain. So if anyone presents with chest pain shortly after the 2nd dose of the vaccine, they all presented within 2 to 4 days after the vaccine, then they should be considered for assessment of myocarditis. They all had positive troponins, they had ECG changes, and they also had imaging findings. Most of them were treated with NSAIDs only. 4 of them in those cases were treated with IVIG and steroids, and many recovered with no known sequelae. There is some thought, and yes, the CDC in the States and the Israeli Health Authority are monitoring these cases. There's a potential that maybe these younger adolescents and people should only get 1 dose of the vaccine and not 2 doses, but definitely we need more information. There's also some question about what is the natural prevalence of myocarditis in this particular age group and in young men. So this is a bit higher than what one would expect, but again, it's difficult to say.
Excellent, thank you so much. So I'll pass along to, thank you for having the privilege of leading this, and I'll pass it along to the organizers to transition us to the next phase, the networking phase.
Thanks so much, Ruth. I think it's been a wonderful morning. Leahy and I were a little worried this morning with this being our first fully virtual symposium. I think it's gone really well. The talks have been so informative, and I want to thank everybody that has participated. I want to thank you, Ruth, all of the speakers, and all of the participants out there that have been listening to us and submitting the really thought-provoking questions. We thought it was a little hard to get our heads around cardio room in such an intense way when we've all been going through so much with COVID, but it's so nourishing to actually to be thinking about complex chronic diseases beyond COVID. For me anyway, it helps my brain. And so thank you to everybody for such fantastic, thought-provoking and informative talks. So I think we've come to the end of the symposium. We would like everybody to complete the evaluations. It's really important to us to get the feedback so that we can improve on this symposium next year. Each year we have taken the feedback and tried to incorporate suggestions into the symposium and selection of speakers and the discussion. So please do provide us with that feedback. And do remember that you qualify for CBD points towards your professional development. I think that's all that we have to say. Is there anything else, Lihi? Other than, honestly, we have to thank Keith again. Keith has been phenomenal. Boy, has he kept us on track, everybody on track, all the speakers. He has a true talent as a symposium organizer and coordinator on top of his PhD studies and being redeployed within the hospital. So can't thank you enough, Keith. Just incredible. And also to the Faculty of Medicine for the conference platform. They've been incredibly helpful and got us through this, and obviously to our sponsors as well. Big thanks to them. We couldn't do it without the sponsors. I think that's all from me. Lihi, anything else from you?
Much. Have a great weekend. Thank you all for attending, and for the panelists, thank you for staying until the end. Thanks.